So going on to where are we in MG presently? It's still considered as a rare disorder, as you all know. It is a disorder of neuromuscular transmission, which I think by now all of you are aware of it and know a lot about it. I don't need to go into the details of that. And it's an autoimmune condition, which and it can also present as a congenital form. And as you know, like I said, it's a rare disorder with only about 20 per 100,000 people who have this, about 200 to 400 cases per million population. And as we know, women have more instance than men of having this condition. And there are two bimodal instances that we see. That is that, you see a younger population in their 20s and 30s, and then you see in the other population, which is like in the 50s and 60s. And about 5 to 10% of the patients with MG also have other autoimmune diseases. That's one of the reasons why we ask people who come into our clinic with MG, whether you have other autoimmune conditions or if you have a family history of autoimmune. How many of you here have like other autoimmune conditions in addition to myasthenia gravis? There's a few of you. And how many of you have family history of autoimmune conditions? So you can see quite a few patients there have, people have their family history of similar conditions. So there are two main forms of myasthenia gravis that we need to look at. One is the autoimmune, where, as you all know, there are various antibodies that have been identified over the years. The acetylcholine receptor antibodies, which have been identified as early as 1976, and this is seen in about 85% of the patients with generalized myasthenia gravis, and in ocular myasthenia gravis, which is a little rarer condition than the generalized, which is about 50% of the patients have the acetylcholine receptor antibodies. So over the years, we have tried to find, is there another antibody that, that we can identify in the myasthenia gravis group, and we have seen that about 40 to 50% of the patients who do not have the acetylcholine receptor antibodies have this other antibody, which is called MuSK antibody, which is muscle-specific tyrosine kinase, and I don't think you have to remember the whole name as far as you remember the MuSK there. And how many of people here have this condition? As you can see, it's a rare condition. It's only about a few. I see only about 2 people having that here, and it is a rare condition compared to the generalized, the other acetylcholine receptor positive antibodies. And in addition to this, we have tried to look for other antibodies in people who have look like MG, but still don't have any antibody that we could identify. And the other antibody that we have looked at recently is the LRP4. So it is not a huge percentage, but again, maybe we need to look at it more in all the seronegative patients. Right now, the incidence is 9 to 10% of the patients with seronegative have this double seronegative may have this antibody. In addition to this antibody, the Spain group has also looked at another antibody, which is the cortactin antibody, which I don't think any of you probably have it because right now we didn't test for it here. And this is not commercially available right now. The ones which are commercially available are the acetylcholine receptor antibodies, the MuSK antibodies, and even the LRP4 is recently available for testing. And Athena Diagnostic, you're right. So that's, and actually there's a study ongoing where you can get free testing through our clinic also. That's how we identified our group of patients. There you go. That's good. And then in addition to this, we also have, this is the autoimmune condition. We think there might be other antibodies that we didn't identify up till now. They could be people have looked at agrin-associated antibodies and then titin, ryanodin receptor antibodies. Again, we have to remember that these may not be specific or sensitive. At this point, there's a lot of research going on in this area to find other antibodies. And then in addition to the autoimmune forms, there's a congenital form, which is less understood. Again, it's probably more common in younger population, when you don't find an antibody, we think of congenital myasthenic syndromes in this group of patients, and it's less common, and it's a heterogeneous group, and usually these patients do not have respiratory muscles involvement as much as other weakness, but there is an infantile form which can present with severe respiratory weakness. And looking at the symptoms, the most common symptoms, even after we know so much of the myasthenia gravis, the most common symptoms, as you can see, is the eye symptoms, which is the drooping of the eyelids and the double vision. So majority of the patients, even if they have generalized myasthenia or ocular myasthenia, they present with these symptoms as the initial presentation. So as you can see, and you can see, like Amanda had talked earlier about respiratory failure, it's only about 1% of the patients actually present with the respiratory at the onset of the symptoms. So fatigue is another one, leg weakness. You can see that generalized weakness is seen in about 35% of the patients with MG. And going on to MuSK, how do the MuSK patients present? There are a slightly different group of patients. They have present mostly with, they're mostly younger women. Predominantly, they have facial involvement is what we have seen. We have done a study looking at, a retrospective study looking at our MuSK patients as well as nationally with other centers, and we looked at what are the characteristics. Are they different, significantly different from other myasthenia gravis patients? We didn't see a significant, I wouldn't say it's a whole lot different from generalized myasthenia gravis, but patients with MuSK present more with bulbar symptoms. What I mean by that is the swallowing, the speech, those symptoms are more common in MuSK patients. And the treatment is a little more difficult is what we noticed with MuSK patients compared to acetylcholine receptor antibody positive patients. And they have mild limb weakness compared to the bulbar symptoms. That's the symptoms of the mouth and speech and swallowing. So once we clinically think that the person has myasthenia gravis, what is the next step is, again, like what we discussed, is trying to find what antibodies do we have in the blood. So we get the acetylcholine receptor antibodies, and then if that is negative, most of the labs do automatically, like if acetylcholine is absent, they go ahead and do the MuSK, if we ask for them to go ahead and do the MuSK. And then the LRP4 is something we have to request through a special lab, like one of you mentioned, through Athena Diagnostics. So not all labs do this at the present time, but hopefully in future we'll find more labs doing that testing. And in addition to this, we want to make sure there's no other cause for myasthenia gravis, or there's no other cause for the weakness, or no other cause that is leading to the double vision or drooping eyelids or weakness in the arms and legs. Because if you look at it, even vitamin B12 deficiency can cause weakness, generalized weakness. If someone is severely deficient, you can present with, so we do check for some of this, and people who have thyroid abnormalities can have like double vision and eye symptoms also. So we need to make sure that you don't have another condition that's causing your problem if the antibodies come back negative, especially when we're thinking of seronegative. We want to make sure we're not missing another condition that's causing these symptoms. And in addition to this, we check for the sedimentation rate, ANA, looking for other autoimmune conditions, because we see that they're associated with other autoimmune conditions. So in addition, once we diagnose someone with myasthenia gravis, the first thing we all do, as you all know, all of you might have had this test done, which is the CT scan of the chest. We want to make sure there's no thymoma associated with that, because about 10 to 15% of the patients with myasthenia gravis do have a thymus gland tumor, and that has to come out if you have a tumor. So we check for that. And in addition to that, sometimes if we suspect that this doesn't look exactly like myasthenia, or we think that could it be something else, we get the MRI of the brain, which is not a required test, but most of us end up doing that to make sure if your antibodies are negative, and we want to make sure there's nothing in the brain that's causing your drooping eyelids or double vision, symptoms, other symptoms. So we get an MRI of the brain, especially to look at the eye ocular findings. And then look, the other diagnostic tests that you probably came across is, one is the ICE test, which is not commonly done by neurologists, but you might see more in ophthalmology clinics. But again, it's one of the tests that can be done where you put ice on the eyelid that is drooping. You want to have something that you can measure. Obviously, if you have generalized weakness, you can measure that with an ice test. It'll be difficult to have ice all over your body. So, if you have a drooping of the eyelid, then you just put ice on that and see if it improves after that. So one of the mechanisms that cold improves the symptoms is it slows down the breakdown of the neurotransmitter, that's acetylcholine. It slows that enzyme that breaks it down. So you have more of the neurotransmitter that helps at the neuromuscular junction. So that helps with improving your symptoms. It's a brief improvement, but it does help. That's one of the way you can test in your clinic if you don't have anything else accessible. The other thing is edrophonium test, which is fast-acting mestinon. It's basically works really fast. As soon as you basically inject about 0.2 milligrams of the edrophonium into the IV line, and you're looking at the improvement of the ptosis, that is the drooping eyelid. Again, this one also you need to have something objective to see if we can measure it. Again, it would be hard to measure just generalized. If someone is saying I'm having fatigue, it would be difficult to test that. And so you need to have something objective to measure, like, we measure the distance between both the eyelids and see if it improves before after the treatment. So as you can see in this picture here, you can see in this picture in the first one, I don't know if I can. So in this is before the edrophonium. You can see the eyelids drooping, and in this you can see the eyelids improving after you give the edrophonium test. It used to be called Tensilon test and later Enlon test, but I heard recently that even Enlon is not available right now. So that's something which we learned things along the way, so it might be something else that we will find the edrophonium marketed as. And usually this response is very fast. So as soon as you inject the medication, you see the response within about 5 minutes. And then after that, it doesn't last long either. So it does get out of your system faster. So you see that drooping again. But one of the major problem of doing this in the clinic is there's a side effect with the medication. People can have like slow heart rate and blood pressure problem and bronchospasm. So we monitor that closely, but it's nice. Usually it's done in like a hospital setting or, in some clinics where there's atropine ready, and, this is the medication that we have to give in case if someone develops the side effects. And going on to the other tests that have been developed for myasthenia gravis is the repetitive nerve stimulation. I think how many of you had that in this room? It's not a comfortable test, as you can, as you can remember. I don't think you forget once you get this test, but what we do is we stimulate the nerve and record over the muscle. Just like how you have fatigue with myasthenia gravis, what we are trying to see is there fatigue of the muscle after we stimulate the nerves. And it can be done on the face, it can be done on the arm or in the neck. These are the three areas that we commonly do the testing on. And what we are trying to see is there a decrement, that is decrease in the response with the stimulation. So the decrement that we used to use and we still use is greater than 10%. The decrement is what we are seeing from when we give 5 stimulations, we are trying to see is there a decrement from the first to the last stimulation. And usually we want it above 10%, but in recent years we are seeing that one of the studies that has been by Dr. Vera Brill and the Canadian group, they have shown that using 7 to 8% cutoff, that increases the sensitivity. So you can use a lower number than 10% decrement. Is that something which we need to use, but we probably need few more studies. And they have shown that it increases the sensitivity. That is, it can capture more patients with myasthenia gravis by using a lower cutoff, but at the same time, and the specificity is also high. And in addition to the Canadian study, we also did a similar study at KU, and our study also showed that greater than 7% decrement and up to 2 minutes. Normally we do it up to 6 minutes, and we were trying to see, do we really need to give that many stimulations? Do we have to do it up to 6 minutes? And so we were trying to see, is 2 minutes enough, or is it 1 minute enough, or is it just after, that is after the exercise, exercising the muscle. So these are some of the latest studies that have been looked at. And the other way you diagnose myasthenia gravis, if you have all of these negative, is a single fiber EMG, which not many people do that examination, but it is, putting a needle into the muscle and you're just looking at the muscle activity. It is, again, it is a painful study, I would say, because many people find it uncomfortable getting that done. But what we are trying to see is jitter, what we call as jitter. This is a normal single fiber EMG, and what we are trying to see is, there's variability of the firing of the muscle fiber. That's what we are looking at. With myasthenia gravis, the neuromuscular junction is not well formed, and so you find that there is variability of the firing of the muscle fiber. And that's what we are trying to capture. And the most common sites that we do is in around the eye, the muscle that closes the eye, or you can do it in the arm. And those are the two common sites that we do, but there are other muscles that you can test for this. This is a very sensitive test. It's sensitive it's positive in about 90% of the patients with myasthenia gravis. Again, I wouldn't say that it's 100% for any test. There is always people can have without any of these tests, but it's the clinical judgment which is very important out of all these. And so this is how you diagnose your diagnostic test for myasthenia gravis. And then we looked at, so what are the outcome measures? Like, if you have a treatment given to you, how do we know that that treatment works on you or not? So clinically, in the clinic, we can say that the patient or someone has improvement in the eyes, or improvement in the drooping of the eyelids, or double vision. But for research purposes, we do need more than that, more than a physician just saying that he improved or he did not improve. We are trying to see, is there an objective way to measure? And that's how we develop these outcome measures. We're trying to see, if a medication is given, how do we know this improves? So these have been, you might have had your physicians asking some of these questions in the clinic when you come in, how far can you walk? Are you having double vision now? Are you having drooping eyelids? So that's some of the things that you might, so these are the outcome measures that have been that are being used right now, which is the Quantitative MG Score, the Myasthenia Gravis Composite, and MG Activities of Daily Living. As you know, that's an important thing for a person who has Myasthenia Gravis. It's not just whether your eyelid opened up or not. You want to see, are you able to do your activities of daily living? Did they change? That's another thing you want to look at. So that's something which we want to capture with the outcome measures. And the MG quality of life. So we'll go through some of these. And looking at the Quantitative MG Score, this is the most common one that has been used for most of the studies. As you can see, it tests the double vision, it tests the eye symptoms, the weakness of the arms, and it's a score of 1 to 3. You give the 3 being severe and 0 being normal. And the total score is 39. So the higher the score you have, the worse MG you have. So we are looking at an improvement of a certain number to say that the medication worked or medication did not work. So this is one of the commonly used myasthenia outcome measure in most of the research studies. And then the MG-ADL. This is the other you probably heard this from the study, the Solaris, all the studies that are being done. Most of these outcome measures are used in all of the studies, but there is usually one primary outcome that you want to choose. And this has been used commonly in recent years because of the simplicity of using it. It's only 8 questions, and you're asking someone who with MG whether you have like difficulty talking, difficulty chewing, difficulty swallowing, and you're giving a 1, 2, 3 score. And you probably notice that we ask this even in clinics as a routine care, so that we know when you come back the next time, has it changed? Because I think we all tend to forget all the symptoms, that you had the last time 6 months ago when you came in. We wouldn't remember all of it, but this is an objective way to remember whether you changed from the previous one or not. So it is a good outcome tool to use. And so this is how we also know that whether you improved or whether you got worse from the last time or whether you got better, in addition to our examination. I wouldn't say that any of this would take a place of our examination in the clinic. That's the most important thing. A clinical assessment is most important, but these also help us assess and make sure that we are going the right way in treating you in the clinic. And so you can see the MG-ADL, this is the 8 questions, and it's pretty simple to do. It takes about 5 minutes in the clinic, and this has been used as an outcome measure in many of the studies recently. And the MG Composite, this has been developed by Ted Burns, and some of you might know he's also an MG specialist in Virginia, and he actually had he took some of the other parameters from the other outcome measures and combined it together to make it more efficient. And this is one of the outcome measure that has been recommended by the MGFA to use in Myasthenia gravis, which is, again, the MG-ADL, QMG, MMT has been used in this. And going on to the other, which is the MG-QOL, this is the quality of life. 15, again, you can see some of the measures. I'm sure some of you have experiences. You're trying to say if I'm frustrated with my condition or I have trouble with my eyes. So we try to capture your quality of life because that is an important factor when we are assessing how the treatment works or not. We want to know did your quality of life improve or did it get worse? Or, that is an important measure, not just whether your eyelid opened up or, you had improvement in the weakness. We want to look at the quality of life also. So this is one of the measures that has been used in the treatment outcomes to look at research and also the treatments. So I'll just briefly touch the treatments, and then Dr. Dimachkie will be expanding a little more on the latest treatments. But, looking at the treatment of MG, we have come a long way, from early 1930s when first mestinon, or, it's called physostigmine at that point, and neostigmine were actually identified or discovered. This was in 1930s by Mary Walker. Since then, we had thymectomy, started in 1930s, and they've noticed that by doing thymectomy, you improve the symptoms. And then in thymoma patients, although the recent literature was on even patients who do not have thymoma, thymectomy does improve. That was in 2016. But in between, we have the steroids were found and discovered in around 1960s that showed that there's improvement in MG with steroids. And then we have Imuran, as you all know, azathioprine, the cyclosporin, IVIG, and then recently the eculizumab is the latest one. As you all know, it has been recently approved by FDA for the treatment of myasthenia gravis. So we have come a long way from 1930s to now. As you can see, research has been ongoing, and there are some. If you look at, again, when we try to decide which treatment to use, there are many factors that go into the decision. It's not just whether the treatment works or not, it's also whether you have side effects, whether are you having side effects from the medications, how fast does it work, and so there are a lot of things that go into deciding which treatment is appropriate for you. So we looked at, if you look at the timing of in each of these treatments, when they start to work, the edrophonium is fastest, and then you have the pyridostigmine, and as you can see, the eculizumab, that is the Soros, it takes about 2 to 4 weeks. Azathioprine may take as long as 18 months. So some of them may take a longer time to see the actual benefit. So that's one of the things we tell our patients in the clinic. Don't just stop it right away saying that it doesn't work, because some of them take a longer time to actually work. In the meanwhile, I mean, we do try to give other medications that work faster, but some of these long-term therapy, we need to continue for a longer period of time to see the benefit. So those are, and then again, the cost is an important factor, I think, in the management also. You know, as you all know, the most cheapest one would be the prednisone, which would be only like annual cost you can see there, it's about $15, which is, you know, way cheaper than the eculizumab, which is, it costs about $600,000 right now, because it's the newest medication that has been approved. And so as the cost, again, you have to look at insurance approvals for these, and some of them lie in between, like the mycophenolate, that's the Celsep, the Imuran. These fall somewhere in between, like about $2,000, a few $1,000s per year. So you can see there's like from $15 to anywhere to $600,000. So there is a lot of variation in different medications. Again, you see which one works best for you. Again, the insurance approvals, and so a lot of factors go into what treatment we use. Or, I mean, we do have some first-line medications that we use, but in addition to that, we also have to consider all these. So there have been quite a lot of studies published on therapy of MG. As you all know, over the years, we've been working on trying to get a lot of research and try to do, I mean, we are involved in most of the studies that are ongoing right now in US, but there are a lot of studies in MG and trying to find new treatments, trying to find new antibodies. And so there's a lot of research going on. And most of these studies are non-controlled, non-blinded. That what I mean is that when we say blinded, the patient doesn't know what medication they're getting, and we don't know what the medication they're getting, and we're trying to compare it with placebo, which is like a sugar pill, you know. But most of the studies, it's hard to do that, and we realize that it's very difficult to enroll patients in myasthenia gravis, and you know, we all appreciate that most of you are interested and do support us in the research, but that's how we are able to find new treatments, you know. And many simple observational, most of these studies, as you can see, most of these are simple observational. Okay, but we say like someone had benefit with IVIG, or we look at a retrospective look at our database and see how many patients were on IVIG and how they improved. So these are like observational studies or retrospective studies. That's one way how we say that this treatment may work. But what we really need is the randomized controlled trials to say this is better than a sugar pill or better than, you know, but it's difficult to do those studies, you know. And the variety of ways in measuring the response. Again, is this the right outcome that we are using, or is it something else? So the MG randomized controlled trials, as you can see, the big list, I'm not going to go through all of it, but let me go through that. So as you can see, the list of studies that have been ongoing, there are more than 21 studies there. This is just the list. I put it together, but we have a lot more, more studies being added. As you can see, some of them are positive, and some of them, they were negative. Actually, majority of the studies that we see are negative, but you can see some of them, which are bolded, are positive studies, including like Imuran, the cyclosporin, and these are some of the medications that we use: plasma, IVIG. And thymectomy, which is the recent one that you all know, and eculizumab, which has been a positive study compared to placebo.
This is from an older study that was published by Jackie Pallas years ago, looking at the efficacy of a drug that many of you have used. How many of you have been on azathioprine, also known as Imuran, by show of hand? Quite a few. How many of you have been on Celsep? quite a few too. So these are some of the most popular medications that are used as adjuvant, which are helpers, immunosuppressants in MG field. But this is based on this study. And the reason I bring up this study, not to teach you about how the drug works, the dose, the doctor will figure that out, but to show you this curve here. And this curve shows you that where the benefit of azathioprine started to show itself in the way of sparing the amount of corticosteroid was not at 6 months, it was right at 12 to 18 months. The point being that once your doctor helps you by putting you on this medication, you should not be anticipating that your MG dose of steroid will be reduced or your MG status will improve in a few weeks or a few months. It may be a longer haul. So it's a good medication. We have proof that it does something good to your MG in the way of reducing those of steroids, but it doesn't work right away. Whereas if you think of good old prednisone, it works pretty quickly. Half the time in MG, prednisone, when you increase the dose in the case of mild worsening of MG, you can see an effect within 2 to 4 weeks. So that's quite a bit of a difference, 2 to 4 weeks versus maybe 6 months to a year out or longer. That's azathioprine. This is a study that doctors Barron and Pasnoor led. This is looking at a good old cheap rheumatoid arthritis drug called methotrexate. And they tried to see, in looking at a multi-center study, it was a North American study, one site at University of Toronto and 19 other sites in the US, that enrolled 50 patients with MG to see if methotrexate would help with reducing the dose of prednisone in people with MG. Some of you recall the recommendations of the MGFA as to what outcome measures should be in any study of MG, one of them being the prednisone area dose under the curve, and that's what the study was trying to accomplish, to see if methotrexate does that. The quick answer to that, however, is that it didn't do that, but we think that there are several reasons why it didn't do that. One of them is this, but before I get to that, is the study probably was too small with 50 patients. Most MG patients are much larger. The other phenomenon is that if you look at some of those, what we call secondary endpoint measures that have to do with the MG composite that Dr. Pasnoor talked about, the QMG, that QMG was refined by Dr. Barron, these showed a signal whereby patients were better, but their prednisone dose was not better. So there's still a little bit of equipoise around it. And this is another piece of data I'm showing you, which is looking at polyglutamation. We think that the degree of polyglutamation correlates with the biologic effect of methotrexate. At least this is data from rheumatoid arthritis. So we have that data right now, and we're analyzing it, we're sifting through it, sorting through it to determine if there were some patients within the group of the methotrexate group that had higher degree of polyglutamation and a better response compared to those that had lower degree of polyglutamation. And there are many reasons why studies can be negative. I mean, it could be that here in this case, that methotrexate is not a good drug for myasthenia gravis altogether. It could be, there's some phenomenon called regression to the mean, which is if you keep on measuring the same thing over and over again, the average kind of defaults to kind of somewhere in the middle of the values. And because in research study, you know this, we keep on measuring every month something, the QMG, the dose of prednisone, and so on and so forth. So we fall sometimes victims of that in doing research. The outcome measure, the MG composite, is the recommended primary outcome measure for efficacy by the MGFA. Is this the ultimate right outcome measure? I think the ultimate validation of an outcome measure is by showing that it can result in a drug demonstrating a positive effect on MG. That's the ultimate. And I think the MG composite is up and coming in that way, and hopefully such a study will be designed and demonstrate its true face validity. And then how to account for missing data points. And that got us in the methotrexate study. do you do? Like if someone drops out, there are many reasons why people drop out from a study. Sometimes it's a social convenience, right? I don't want to do this study anymore, I'm tired of it. Or it could be because they have a side effect, or it could be because their MG is worse. So how do you account for people dropping out? What dose of prednisone do you give them if they stop halfway through the study? Right? That can get you a positive study or a negative study can make the difference there. And MG is very common, right? There's so many of us here with MG. This is looking around the nation. We have a little over 100 people in the room, maybe there are a couple of hundred altogether around the area. So this is a rare disease. When you're trying to recruit into rare disease, you always end up with needing to do adjustments by extending the duration of the study or adjustments by modifying your criteria to get patients into the study. And sometimes we assume that your MG is similar to your MG and similar to your MG, but we learn differently that there are other determinants of why each person's MG may be different, and that's something we don't understand fully well. But I'm going to switch gears and talk about something that we're all excited about. Clearly, there's a cost associated with eculizumab. This is the complement inhibitor drug that was initially approved by the FDA for treatment of a urine condition called PNH. Paroxysmal is P, N is nocturnal, meaning at night, hemoglobinuria, people that wake up with blood in their urine at night. That's what that condition is. It's a complement-mediated disease, and this study of eculizumab, this complement inhibitor, showed that it does work in people with MG, and it works quite quickly, actually, in doing that. Now, some of us like p-values, and we like them to be smaller than 0.05, but the FDA looked at the totality of the data that showed that there were many of the outcome measures that were positive, and when patients who were initially in the placebo-controlled 6-month part of the study, the placebo group was converted as well as the active treatment group were converted to open-label eculizumab, their MG-ADL really followed suit and improved really quickly and briskly, as did the active treatment group earlier on in the first part of the study, meaning that there was more support, more proof for efficacy. So this is an exciting development that as of October of last year, we have this FDA labeling approval, a drug that's more cumbersome to use. It's IV, it's every other week. You have to have a vaccine beforehand in order to use it. But still, it's a really tremendous step forward for the field of myasthenia gravis treatment. This is the other advance that happened, again, within the last 2 years. This is a study that's been going on for 6-7 years, looking at the value of removing the thymus gland in people with myasthenia gravis. This is in folks who are seropositive, meaning that they have the antibody to the acetylcholine receptor. And it's been a long debate as to whether thymectomy is or is not effective. And this is kind of the study that put the nail in the coffin. And it tried to answer 3 different questions. One of them is that is thymectomy, does it improve your strength? That's number 1. Number 2, does thymectomy allow you to cut back down on the dose of prednisone? Because your strength can be better, but the dose of prednisone can be higher, and then that kind of doesn't tell you which did what, right? And then, of course, thymectomy surgeries. This was done in the context of this research study by cracking the chest open. Does it mean that you're going to get in more trouble after that big-time surgery compared to not having the surgery? It was single-blind, meaning the patient knew what they got. They didn't crack the chest open of the patients and leave the thymus gland in versus cracking that open and removing the thymus. It was single-blind. The patient knew what they were getting, but the doctors that were part of that research study did not know where the patient fell in one group or the other because they were a high turtleneck collar when they came back for their visits. The patients did. And then this is from looking at, does it make your myasthenia strength better? And using the QMG score that Dr. Pasnoor alluded to a bit earlier on, you can see by about 3 to 4 months, there was a separation in the thymectomy group. A lower QMG score is a better score. You could see a separation that was significant. That took us by surprise because all of us expected if there was an effect, it's going to be delayed, maybe 6 months, a year, even longer. We've been speculating it's kind of a delayed effect. Even 3 years was not out of the realm of what we thought would be the effect of thymectomy. But not only that, the dose of prednisone was also reduced within that time frame, meaning that those that improved, that were improving in their QMG, meaning their MG was better, it was not really because they took more prednisone, they took less prednisone, it turns out. And not only that, looking at outcomes of safety, meaning admissions to the hospital, infections, complications, they were lesser in the thymectomy group. So now we know three things. For people with myasthenia gravis that have the antibody positive titer, that thymectomy is safe. It helps improve the status of your myasthenia gravis. It can help you cut down on the amount of prednisone that you're currently on. And to be honest, right now, our patients, we don't go the open transthoracic approach. There are several studies that show that with robotic approach, with transcervical approach, you can have full removal of the thymus, and that's why we refer our patients with AChR antibody positivity for that approach, the robotic approach at our institution. So as far as first-line recommendations for treatment of myasthenia gravis, and I think Dr. Pasnoor covered some of that, of course, there's Enlon, there's pyridostigmine, prednisone, and thymectomy. I think these are some of the first-line treatments. So when you go to your doctors, if mestinon for a lid droop is not working, I think the next step is to go to something of a corticosteroid, or wait and see. I mean, you could argue with me, I don't have much of a problem with a lid droop, but it's bothersome enough, or you're having double vision, odds are good old pyridostigmine is not going to cut it. You're going to have some prednisone as a first-line therapy, and then the second line or a list of different other agents listed here. But before you get even to a second line, then the idea is that you would consider thymectomy. I think this is based on the data, the proof that we have. Thymectomy should be right at the top of the discussion with your physician. How many of you have had thymectomy? How many of you have been told or discussed about thymectomy but said, yeah, I really don't want to do it? Okay. How many of you wanted to do it but it was too much of a surgical risk? I have one patient like that. No. Okay, so I mean, there's a discussion going on about thymectomy. It's important to have that with your physician if you've not already had it. And then as far as second-line drugs, we have data on not only azathioprine, but also cyclosporin, tacrolimus. We have data on immunoglobulins that makes it a second-line. And in third-line interventions, we have proof of efficacy in the setting of worsening of MG or chronic MG management from our experience in plasma exchange. I showed you the methotrexate results. I think that should be within that third-line group. And CellCept, there have been 2 negative studies. But maybe I should poll the physicians in this audience. How many of you still feel CellCept might work in some of the patients? Some of us do, and some of us still use it. And so the MG physician field is kind of divided over that, but we have to listen to sometimes what the patient's bodies are telling us in the way of response, because studies look at groups of patients rather than individual patients. And as a fourth-line agent, now that we have proof of efficacy, eculizumab, and we're all waiting for the results of the rituximab study to be announced. Did some of you participate in the rituximab study? Okay, so this is an NIH-funded study. I'm one of the co-PIs on that grant. I know the results of it. I'm not supposed to share it with anyone. It'll be announced to the public at the Academy meeting next week. We have, I think, on Wednesday of next week, actually, it'll be announced. So stay tuned. This may pull rituximab up on the list or may take it off the list. But clearly, there's one subgroup of myasthenia patients that benefit from rituximab. We will never do a research study for that subgroup to look at rituximab. It's not practical. They've already gotten it. Does anybody know which subgroup benefits from rituximab? With MuSK. That's not going to change that, because the study that is about to be announced, the results of, is about AChR antibody, the acetylcholine receptor antibody. And finally, anybody has been on Cytoxan? You have been. Anybody would like to be on a drug called Cytoxan? The name tells you quite a bit about it, so it's not that used, but it's a kind of last resort. So then there are other studies looking at symptom treatment. This is a study of a drug that strengthened muscle contraction. There was early evidence of some improvement in some of the parameters, the vital capacity in that case. We were part of that study. There's a study by GSK looking at the antibody to B-cell activation, the results of which are not published yet. There's also this NeuroNext study, the one of rituximab, where we're hoping to disseminate results next week about the results of this study. Griffiths is trying to do 3 different types of approaches to myasthenia gravis. One of them is to answer the question of, does getting IVIG improve your chances of reducing the dose of corticosteroid? The second question is, does IVIG improve your strength, your myasthenia gravis status? And the third, if you're worsening and have moderate to severe MG, is that a good treatment for you? So the studies, the first and second study we were part of, they finished enrollment. The 1306, which is the corticosteroid sparing, just finished enrollment just in the last week or so. So we await announcements about results of that, and hopefully they will be positive. This is my study looking at evaluating patients who have MG and are currently on IVIG. Some of our patients are, since they have failed other therapies, and trying to see if giving the immunoglobulin under the skin is a valid way of treating people with MG while maintaining stability. We've enrolled 23 subjects in the study. We're not royalty. We call them subjects when they enter research, okay? That's the technical term. And so we're locking the database in May. We're going to be hopefully having a presentation at the annual MGFA meeting coming up to announce the results on that. And then there are other experimental drugs being tested. This is a study of Argin X. It completed enrollment. We don't know the results of that yet. It has to do with inhibiting the recycling of the immunoglobulin molecule. It goes in the cell, then leaves the cell. If you block its exit from the cell, then you can reduce immunoglobulin levels. So that's one approach. There's also the study of this monoclonal antibody. They call it Rosie. Actually, the drug company, UCB Pharma, calls it Rosie. They just finished enrollment on the study. We're hoping to see results of that. And then there are other ongoing studies. So really what I'm trying to convey to you is that it's an exciting time to be in the MG field. It's an exciting time to be an MG patient because there are so many positive trials in the last decade that have really advanced the way of how we manage myasthenia gravis. We can't claim 100% success, but our success rates are going up exponentially.